This is the Psychedelic Medicine Podcast.
Hello and welcome to the next episode of the Psychedelic Medicine Podcast. I'm Dr. Lynn Marie Morsky, your guide on this journey, and this week we're going to be discussing psychedelics and seizure disorders with Dr. Evan Lewis. Dr. Lewis is a Canadian neurologist and holds an appointment as assistant professor in the Department of Paediatrics at the University of Toronto. He has a special interest in psychedelic therapies for the treatment of neurologic disorders, including functional seizures. Now, before we get to Dr. Lewis, just a reminder that the Psychedelic Medicine Podcast is for educational and informational purposes only. Nothing here is to be construed as medical or legal advice. And a reminder that if you are a clinician and you'd like to learn more about how psychedelic medicines can help your patients with seizure disorders or mental health conditions or general well-being, we would love to have you in the Psychedelic Medicine Association. It is our mission to educate you on those therapies so that you feel comfortable discussing them with your patients and so you're comfortable asking patient questions when they come to you with them. So if you would like to learn more, please head over to psychedelicmedicineassociation.org. Now, without further ado, thanks so much for joining us today, Evan.
Oh, such a pleasure to be here. Finally, Limri, finally.
Finally, yes. I mean, I think we've been talking about since maybe June of last year when we saw each other in Denver. So I'm very happy to have this. Yes. Evan, if you could start by telling us a little bit, we're going to talk about epilepsy. We're going to talk about functional seizures. I think functional seizures may be something that a term many aren't familiar with. So can we start with you explaining what those are for us?
Yeah, sure. I think it's going through some name changes over time. So some of the listeners might be familiar with some of the older names or some of the other names that are currently in use. But first, it's really important just to define epileptic seizures. So one way to think about epileptic seizures is electrical seizures. So these are typically seizures that result from synchronized electrical activity in the brain that is not normal. It's not the kind of normal electrical activity we'd expect. So when someone has an epileptic seizure and you put an EEG on their head to measure electrical activity, you see abnormalities there. The big differentiating factor with functional seizures is that if we did the same thing, if someone was having one of these episodes and we put an EEG on their head, we actually would see a normal EEG, or we would not see the same activity. So we know functional seizures are not due to the same electrical phenomena that characterizes epileptic seizures. So that's a real easy way to just separate these two, and a very important distinguishing feature, because both epileptic and functional seizures can look very similar. And it really does take a trained eye and a trained neurologist and even a trained epilepsy specialist to be able to distinguish some of these seizures just by looking at them. And there are many different signs, and there's some great work that's been done in this area to help do that. But that's where the skills and specializations of a particular neurologist or an epilepsy specialist will come into play. So just to kind of finish this off, so what is a functional seizure? It's really hard to capture this. Other names that have been used in the past: psychogenic non-epileptic seizures, pseudo seizures, dissociative seizures, non-epileptic attack disorder. That's typically used in the UK. You hear that a lot. Functional seizures at present tends to be the term that is becoming a bit more favored because of where the understanding of this condition and its related conditions are headed. So that's a bit of a primer on it. I didn't really get into actually what it is because it really is a hard thing to describe. But one way to think about this, and this is where the dissociative seizure maybe is a little bit more descriptive. So they tend to be episodes where people undergo an experience of dissociation, and that can serve a function depending on the circumstance that someone who's having these episodes. So really kind of think the key takeaways here are they are different from epileptic seizures. They are not due to electrical phenomenon that we see with epileptic seizures. And if anything, they're due to the way in which the brain is functioning, and that can be mapped onto brain networks. So functional seizures at their heart are a disorder of brain networks. And there's many different models that have been proposed to describe this. There's a few kind of prevailing models right now, and I'm not going to go into the details of those. I think that's a very kind of high level description of these, and the main salient points I think we've hit on. I'm sure we'll expand upon them.
Yes, I was going to ask because you said when somebody's having a functional seizure, it doesn't show up as the same electrical activity. Does it show up if you're doing like an fMRI, a functional MRI, does it show up that something is happening?
So no, not to my knowledge. I think there's actually one case report of a functional seizure being captured in an fMRI. I don't recall the findings off that, but again, from one case report, and if there were changes, you have to kind of take some of that with a grain of salt. You'd expect there to be potentially some changes, but maybe not in the moment, or not different from that person's baseline to what's going on in the fMRI. And I think this needs to be teased out a little bit more. And and again, coming from one case report, it's hard to rely on any information from that.
I guess my next question that is related to that is how often, I realize it probably is a wide spectrum, but do these happen to people once a day, once a week? What is the general frequency? Because I'm assuming it's hard to capture something with an fMRI if it happens rarely or, it's unpredictable.
So the presentation of functional seizures is so variable. It will vary in the type of seizure. So it can vary from people with no movements at all having an episode where their behavior just abruptly changes and they're very still and they're kind of, quote, tuned out. This could very much resemble like an absence seizure that we see in epilepsy, all the way to a full-blown generalized tonic-clonic seizure that you would have a very challenging time distinguishing between epileptic seizure, again, for the untrained eye. So that's just the quality of the seizures, but the frequency can also be quite variable. So I have met with people who've had one or two in their lifetime that was spread apart, and I'm seeing them months later, even years later. And then I've met people who have had multiple daily functional seizures lasting 1 to 4 hours each, and going on for years. So it really is so variable. And we see that variation in epilepsy as well. And it's typically related to how severe the person's condition is.
I understand. And moving into our area, what led to investigating psychedelics for their potential to address functional seizures?
Right. So this is it excites me just to kind of think about this stuff as a neurologist, because first I'll just preface this by saying to me, this is the gateway for neurology into psychedelics, is through not just functional seizures, but functional seizures is one type of an entity under an umbrella called functional neurological disorder. Previously, known and still called conversion disorder, or even back, in Freud's time and even up until a few decades ago, hysteria. So hysteria, conversion disorder, functional neurological disorder they're all the same thing. And functional neurological disorder is now defined in the DSM-5 as a diagnosis. And it is essentially the same thing. And it refers again to dysfunction of the nervous system. Just as a little bit of a segue, this is a nice kind of way to characterize this. I think this is very helpful for patients. It's certainly an oversimplification, but it's a nice analogy. You can use the idea of a hardware and a software problem. So neurologists we love our hardware problems. I think actually doctors love hardware problems.
Right.
There's only one realm that really deals with the software, but doctors love our hardware problems. And so the nervous system has its hardware. It's got its brain and its spinal cord and all its connections and the muscles and everything. That's all hardware. But what runs the whole machine is the underlying software. And most diseases are dysfunction in the software. So this is where, something like conversion disorder, people can display all sorts, conversion disorder, now functional neurological disorder, people can convey all these types of symptoms that are very kind of weird and wonderful and don't make sense to a lot of people, because everybody's looking for a hardware problem, right? When they're not. It comes down to the underlying software. So, coming back to this, I kind of got lost in what the question was. This happens with this stuff because
why psychedelics might be a good
right.
way to
Thank
address
you.
this.
Yeah. Well, psychedelics really are software medicines. Like we know that, and so that really begs the question: what part of the brain do we find the software? And again, an oversimplification, but you can say embedded within brain networks. So the way the brain is interconnected and the way that it talks to itself, and not just in a given moment, which is what a lot of fMRI work has shown. We're capturing all these great, wonderful pictures of brain networks in the given moment, but it's even more complicated than that. It's how are these networks changing over time, and how are the networks interacting with each other and dynamically changing over time. And so you can have disruptions in networks alone, but you can also have disruptions in how the networks change from one to the other. And we're starting to see, and we've seen this a lot. This has been demonstrated by, Dr. Carhart Harris and many other researchers that have shown how psychedelics impact the connectivity of these networks. And even kind of Dr. Manish Gurn now, who's talking a lot about complexity science and how psychedelics not only change the interconnections of the networks, but they also change how the networks dynamically interact with each other. So given that functional neurological disorders, including functional seizures, are dysfunction in how the networks are pieced together, I kind of tell people, psychedelics are brain network medicine. They kind of dissolve those networks. So if the thinking is FND is due to, dysfunctional connection or hyperconnectivity in certain networks, what we have to do is we have to kind of help repair those networks. But first we have to take them apart and build them back up. And the last thing I'll say is, this is why I said, doctors love their hardware problems, when, it's a psychiatrist, psychologist, and the mental health profession. They're all software workers. And what I always say is neurologists, we're the people in between. I just don't think a lot of neurologists recognize that yet.
Yeah. The intermediary kind of
Exactly.
sorts.
Yeah. Or
Yes.
we have like the capability to be that intermediary if we so choose.
Yeah.
And I think our training sucks us into the hardware problem. And this was kind of the separation between psychiatry and neurology that happened in the 1800s with the ideas of brain localization and then continued. But what I love about psychedelics is it seems to be bringing this back now. It really is, for me, the bridge back to that, traditional kind of neurologist, psychiatrist, who are really one and the same.
I love that very much.
Yeah.
Just to put some of what you mentioned in terms, like you talked about Dr. Carhart Harris's research, but I know we've talked a lot in our different episodes about the default mode network. That is one of the brain networks that you're referring to, correct? And functional seizures, what is the name of it? Do we know what brain network is involved in those?
Yeah, so that's a great point. So yes, default mode network is just one of 7 major networks. And again, these networks, it's not just about what's going on in these networks. It's also how these networks all interact with each other as well. And that creates, when in the healthy, normal brain, that creates experience of the world, of our bodies, our minds, our imagination. All of that comes together. Like, for instance, everybody talks about the DMN, the default mode network, as the thing that allows us to, daydream. Okay. But how can you daydream about a Starbucks coffee if you've never visually seen a Starbucks coffee? So when you daydream about a Starbucks coffee, you are also recruiting your visual network as well. So there has to be an interplay there between the two, because you got to recall it from somewhere.
Yeah.
Right. That's just an example. So that's a really important point. I think it gets missed a lot, and especially in the early days of psychedelics, when everybody was talking about the DMN all the time and everything. So when it comes to when it comes to functional seizures, this is the research that we've started to explore, looking, well, what networks are involved in functional seizures. Now, there's been various different brain regions and networks that have been implicated. So functional imaging studies have shown the default mode network as being implicated. A really important part, the temporal parietal junction. So this is where the temporal lobe and the parietal lobe come together and they integrate information there. Though that is that's an area that where a lot of our bodily signals are integrated. And so it's thought that this area promotes our sense of agency, our sense of being responsible for ourselves and the movements of ourselves. Because a lot of the functional neurological disorders, people feel that these movements that are happening in their body, or the seizures that are happening, or the lack of movements that can happen, all these things that we see, again, historically in context of conversion disorder, people feel separate from that. They feel like it's happening to them, although it's their own body. So it's almost like there's a sense of agency that's been dissolved, and that can occur to disruption in networks there. So the temporal lobe is really important. And then the motor cortex is important. something like functional seizures, there's a lot of movement with some of these seizures. So certainly the motor cortex has to be involved as well. So various different studies have shown abnormalities in connectivity within these regions and between these regions in the context of functional seizures. And the problem is some of this is consistent and some of it is inconsistent, much like we see with psychedelics. Right, we've got we've got these great experiments that show us consistency in certain networks that are involved, but then we have that can vary across different studies, but also can vary even between individuals within the same study. So we're answering some of this here, but we're missing some of this piece here. And so what I'm really interested is in what is the overlap? What is the overlap between the networks that psychedelics affect? Particularly ketamine, psilocybin, and MDMA, LSD as well, like the others, but particularly those because there's a lot more work in those. What's the overlap between psychedelics and the networks they involve and functional seizures? And I'm kind of thinking if we've got overlap there, which there is, and this is a paper that we've published that's coming out, then maybe those are the networks we should start looking at as to why psychedelics can be a treatment for these disorders.
Yes. Well, you've segued yourself into it. Please tell us about your research in this area.
Yeah. So that's really the main thing. Like I'm very interested in looking at and determining if psychedelics are a treatment. And again, the theory is all there and makes sense, and we've actually been doing that at my clinic. We've been treating people with FND with ketamine. We were able to access ketamine quite easily here in Canada, as many parts of the world. And we actually published a case report about a woman who had functional seizures. She was having very frequent seizures over the course of 5 years and was treatment resistant. Nothing really worked. We utilized a course of ketamine-assisted therapy over 3 weeks with some maintenance ketamine sessions thereafter. It was oral ketamine and nasal ketamine, not IV. She had a robust response, an amazing response. She went seizure-free for the first time in about 5 years for the following weeks, and then had a sustained response over time, over a year plus thereafter, and was able to really engage in therapy and kind of get to the root of some of the issues that she had, which presumably were related to her functional seizures. And we've repeated this with another individual in practice here who's done fantastically as well. And there's been a few other people with other functional symptoms where really short exposures to ketamine have helped. So that's kind of the clinical fodder I needed, plus what's out there in the literature for me to then, the next step is this paper that's coming out, which is looking at the overlap. So overlap between these networks and determining a mechanism. And then my hope is in time I could be involved in a clinical trial where we could image people before and get some baseline imaging, treat them with a particular protocol, be it ketamine, psilocybin, or another, and then look at imaging afterwards. And I think if we do that and we correlate that with outcomes, we're going to open up the door for a deep understanding of not only just functional seizures, but FND as a whole. And I think it's Stanislav Grof who said that famous quote, right? Like psychedelics are to to biology as the microscope was to it, and botching it a bit, right? And the telescope was to astronomy. But I do think like psychedelics are, to the same tool for investigating these previously medically unexplained conditions we have in neurology.
Yeah, absolutely. Well,
Yeah.
please let us know. By us, I guess I mean me. Let me know when your paper's out, and we will get that out to the Psychedelic Medicine Association members, because I'm sure those who are in neurology will be very interested to read that. And thank you for doing that research. We started by talking about the difference between functional seizures and epilepsy. What, if anything, has been done or discussed about the use of psychedelics in the context of epilepsy?
Yeah, that's also another great question, another strong area where I'm interested, because I am by training an epileptologist. Like that's my pediatric epilepsy and adult epilepsy. So first and foremost, I was that. And actually, when I started to get involved with psychedelics, the FND piece kind of built over time as I started to understand the mechanism. But I really initially got involved because I work with so many epilepsy patients, and the proportion of individuals who suffer from mental health challenges with epilepsy far outweighs that of the normal population. And you just have to think about it. It's scary to have epilepsy, right? It's scary. It affects your life profoundly. There's a lot of stigma around it. You have people who have, very mild epilepsy that can live full lives, but still have to deal with all that. And then you have people who are profoundly affected. So mental health is a huge problem in the context of people with epilepsy. So my first initiation was, well, look, we need neurologists in this space, because who is going to make the call for the people with epilepsy to be able to undergo psychedelics and psychedelic therapy? Who's going to make the call for the patients with stroke? Who's going to make the call for the patient with brain injury? What about the horrible neurodegenerative conditions like Huntington's disease and ALS and all these others where you don't have to read the stats to imagine what that's like. So I always thought, look, regardless, even if there isn't even a condition in which psychedelics are utilized in neurology, we need the neurologist to be able to indicate that these patients are safe, or at least do the work and be involved in the clinical team. So that was like really my first drive. So that begged the question right off the bat. I wanted to know how safe are psychedelics in the context of epilepsy, and nobody knows. All we have is case reports out there. We've got a lot of like knee-jerk reactions of people being, concerned about it, rightly so. But the worst thing you can do in medicine is bring your biases into a situation like this, especially in a population that needs these therapies so much. So, when you actually look at the preclinical data and the clinical data, number one, right away, it's unclear. Number two, it actually maybe doesn't look that bad. Like, again, we need better studies on this, but right off the bat, it doesn't look that bad. So, given all of that, ultimately people with epilepsy, I think it's a risk benefit situation, and you can weigh that. And we actually have weighed that at our clinic, and we've treated a few people with epilepsy, with ketamine, not psilocybin, not MDMA, not others. And with ketamine, they've done great. No seizures. Ketamine, I can feel a bit safer because ketamine's, commonly used as an anesthetic agent, and there's a lot more kind of information out there about ketamine, and people with epilepsy all undergo surgery, and right. And in fact, ketamine is used as a treatment for status epilepticus, as a low line. Like I think it's like you can use as third line or fourth line in some studies, and it's actually used to treat seizures. So I felt more comfortable with that. But at least we can do that. But people right away, I get consults all the time, asking if people with epilepsy can undergo psychedelic therapy with ketamine, for instance.
So what I'm gleaning from this is that there hasn't been enough research to show exactly what the risk is for different psychedelics. Because Have people with epilepsy been excluded from the trials, as far as you know?
Yeah, they have been. So if you look at all the MDMA trials and the psilocybin trials, it's one of the absolute contraindications. So it's one of the exclusion criteria. So we do not have any good clinical data on this. We've got so there's some case reports. So actually, a group of mine and a group of students of mine did publish a very small review looking at psychedelics and seizures and the risk in epilepsy. And when you look at that, I think there was about 10 or 11 case reports. Most of these were accidental ingestions in adults and kids. Some of them were purposeful, people using these substances recreationally. But that, and it's all clouded with just kind of, reports from the medical charts, other substances being used at the same time, concurrent illness and whatnot. So it's really unclear. It's totally unclear, and we don't have any data. So, I don't think it's right to say people with epilepsy cannot use psychedelics, but I also don't think it's right to say they're safe to use psychedelics at this point in time. I think really what it is we need to know this answer, and who's gonna be the one who has vested interest in picking up this information. It's going to be from neurologists. So, to all the neurologists out there, this is that in and of itself is a huge area of study for somebody.
Yeah, absolutely. Is there a thought, because you covered why psychedelics would seemingly be impactful for addressing functional seizures, do you have a rationale or thought as if they would have any effect on epileptic seizures?
Yeah, so that's also a good question. So I got one of my students and close colleague, Brendan. He's doing some work on this at his lab at Toronto Western Hospital with Dr. Peter Carlin, and they're looking at this at a preclinical level. So they're looking at this with kind of brain slices and in mouse models. So again, with the question of is psychedelics a treatment for epilepsy, the answer is we don't know. I don't know. I'm not. It's in some senses there's overlapping mechanisms. So fenfluramine is a treatment for Dravet syndrome, which is a really devastating epilepsy that happens in young kids. And fenfluramine is a serotonin agonist. They're similar to some of the psychedelics. So there's overlapping mechanisms, but I think it's unclear. So I think that's a big question mark. And I think more the prevailing question is for people with epilepsy, to be specific, is ensuring that they are safe to have their co-occurring mental health issues treated with psychedelics, and not excluding, and eventually not excluding these people, and having centers that have the expertise to manage this. So it doesn't if somebody underwent psychedelic assisted therapy and had a seizure, let's say, whether it was due or not to the psychedelic, you've got to have the right clinical staff there to be able to support a person like this. And that's possible. That is totally possible. And that could happen with any procedure. That could happen with a person with epilepsy just visiting me in the office. So, but when you have the right clinical team there, I think it gives an opportunity for this population to, benefit from the treatments of psychedelic therapy like the rest of us. Yeah. And I recognize it's early days, but again, this is the call for, we got to figure this out and sooner rather than later.
Right. No, yeah. Somebody, I think when I was recording an episode yesterday, they're like, well, we don't know all the answers. And I was like, if I only did podcasts where we had all the answers, I would have like 2 episodes. Like, so much of, we talk about what we know and then what we hope to find out, what trends look possible. So thank you for sharing that and sharing what needs to be done, because I always hope that there are some people out there looking for an area of research. The next topic I wanted to probably wrap up with is the potential for psychedelic drugs. Like we were talking about, what is the risk? I recall seeing in a paper that our 2 favorite psychedelic psychopharmacists put out, Ben Malcolm and Kaylin Thomas, about and maybe other people, forgive me if I left other authors out, but they were talking about the instance of I believe seizures on people who were on lithium and then they took psilocybin. Am I correct on that? Can you talk a little bit about that interaction?
Yeah. So lithium is a drug that has kind of like a wide ranging effect in the brain. So we know and this is an area of contention even within the epilepsy realm. Does someone who's on lithium, does that lower their risk of lower their seizure threshold? I.e., are they more likely to have a seizure? So, do we have to be cautious with people who have epilepsy or also on lithium? Now, I have patients who are on this, and hard to say, right off the bat, but theoretically, yes, that's there. And, the evidence on this, you've got reports that show both preclinically and clinically that lithium can be proconvulsant, but you also have reports that show that it's, again, anticonvulsant. Now, when you kind of pair that with lithium and psilocybin, it shows that maybe there's an increased risk here. So, again, I think this is an area that needs a lot more work, because lithium is a relatively common medication. Epilepsy is relatively common. I don't know how common lithium is being used, but epilepsy is 1% of the population. And 30% of the population is drug resistant, meaning they're on lots of medications, meaning their epilepsy is bad. Okay, so that's a large part of the population. And then, as I mentioned, co-occurring mental health conditions in epilepsy are more common. So, things like this, like drug interactions that we pick up with psychedelics, again, are going to be a big piece of the puzzle that needs to be answered going forward. And this specific circumstance is an interesting one in which the neurologists and psychiatrists can come together, because this is important for kind of both of these individuals, because we often co-manage patients like this. So, again, a call to an area where we got to figure this out and know. But I think at this point, I would proceed with a lot of caution for somebody. I think first and foremost, I would be very cautious and have appropriate conversations with anybody who has epilepsy, who is considering using psilocybin, presumably they're going to go do it on their own because you can't access that legally here in Canada. So that in of itself is a conversation to have. Never mind if they're on lithium. So then I would probably be, I would advise them to be extremely cautious. I can't control what they would ultimately do. But if they came to me and asked for that information, I think that would be my response.
Yeah, because that is probably something that Oregonian neurologists are having to answer at this point with patients who might want to use the Oregon, psilocybin system.
That's actually a great point. Yeah, I forgot that it's accessible there. So for sure, right? And these are these things that are going to come up, and again, presumably those are the people that are going to come in and ask, right? Because they have a higher chance of being unwell and not having responded to their current drug regimens.
Yeah, absolutely.
Yeah.
Evan, this has been a fantastic conversation. I have learned a lot. This is a whole different area from what we're used to talking about.
Right.
Can you tell us where to find more about your work and where we can keep tabs on the research you're doing?
Yeah, for sure. So, PubMed's the greatest, that's a start to kind of where some of the publications have been. I'm on YouTube. So I've got some videos on YouTube, planning on kind of adding a little bit more. They're mainly directed at patients to help support patients, but they're informational as well. So that's a place there. And if anybody's interested and wants to connect with me, LinkedIn is that's a great place. But stay tuned. I mean, on LinkedIn, that's where I'll usually post kind of the publications that are coming out or some of the research that's being done. And then, as I said, I hope to put more videos up on YouTube, but I think I need to take some pointers for you how to juggle all these things, given that you run this podcast plus all the great stuff you do. So maybe we can talk offline.
We'll record. We'll get you a little video set up for sure, Evan. Well, this will be fun. But I really appreciate you. First off, just the pioneering work that you are doing in this difficult. The beauty of psychedelics is so often we're finding them helpful in treating things that were so difficult, so challenging to address before, just weren't good answers, and they're popping up as seemingly potential promising solutions. So thank you for the work you're doing, and thank you for coming on and chatting with us today.
Thank you so much for having me, and you said it all there, so I appreciate it a lot, Lynn-Marie.
Looking forward to the next, Evan.
Okay.
And for everybody else out there, until next time. Thanks so much for listening to the Psychedelic Medicine Podcast. If you enjoyed what you heard, please leave a rating or review as it helps others find the show. And if you'd like to learn more, you can find the show notes at plantmedicine.org/podcast, and there's information for clinicians at psychedelicmedicineassociation.org. Our incredible music was by the one and only Porangi. We'll see you next time.